happy to do these last few years. They're very complex cases. And also it's a very, very wide range of complications that we have that endoscopy can really help. And I think endoscopy is the primary way to go in most of these complications. Due to the time restrictions, of course, I won't be going through everything, but I'll be mainly focusing on the leaks, which is the main, most troublesome issue, and some of the outflow obstruction issues. So first of all, the leaks. And I think, yeah, leaks, it's very important for those who are maybe starting in the field of endoscopy to know that it is not just a simple hole that you have to close. It's really a storm. This patient coming in who's already morbidly obese, he has chest problems, he's diabetic, and he has this life-threatening sepsis. So it's really a catastrophe that you're facing. It's not something to take lightly. So our approach, when we started working on this, I think maybe like 12 years ago, is that I think we were one of the first teams that started working with these bariatric specific stents. This is the mega stent from Taiwan. These are really massive stents. We have diameter reaching up to 36 millimeter. They are, have the advantage of being highly flexible, as you see, and really large to reduce the risk of migration. And this is one of the older videos, but I really like it because it shows you many things in bariatric endoscopy. So this is a patient who had Roux-en-Y gastric bypass, presented with sepsis and a leak. He came to us about 2 weeks after the surgery. And here we're at the cardia. And then just after we passed the cardia, first of all, we imagine that this is the lumen or the gastric pouch. And then after closer assessment, we found that the lumen is actually down here. This is the jejunum where we enter now. So we come to appreciate that almost about 50 to 60% of the anastomosis is completely disrupted. So you see here, these are the intact sutures, and all this is the jejunum. So actually, when we find access to going outside into the abdominal cavity, this is something that I'm actually very happy with. We don't actually just pull the endoscope out and then call the surgeon. This is a very good opportunity for me to do some lavage, some cleaning. We do this, we use baskets, we use continuous lavage with saline, sometimes antibiotics to clear the leak cavity or the peritoneal cavity, and then we proceed with doing our procedure. So in this case, due to the very large dehiscence, we decided to do something. We decided to do some approximation first before trying to do anything. So as you can see here, there's just the contrast is going everywhere. There's no like fistula or something. So in this case, we decided just to approximate a little bit the tissues. So we used a Ovesco clip, and this is using the twin grasper. We know very well that any clip you'll put here, it won't hold. We know this very good. But we just wanted some approximation just to reduce the healing time a little bit. So here we applied a Ovesco clip just to approximate. Of course, it's not easy with the fibril tissues, with the fibrotic tissues. And eventually you put one clip, and then we put another clip beside it. We know very well they just hold for maybe a few days and then they fall back. So then we put this large mega stent, and you see the clips here inside. And then we followed this patient after several weeks. So after 8 weeks, we have now this view. The clips, of course, have fell out, but we're starting to have a proper anatomy. So you see here, this is the lumen of the jejunum, but there is still a small tract here, which is becoming now a fistulous tract, but we do have some proper lumen now, which is different than what we had before. Now, when you approach this fistulous tract, now it's different. Now this tract is chronic, it has epithelium, it's epithelialized. So you really have to do something to de-epithelialize this tract to help the healing. So this is why now we decided to do some de-epithelialization using APC. So we try to do some ablation of the edges of the whole tract, right up to the edge. So you're trying to create a new raw surface area. And then we put another one of these large megastents for another 6 weeks. And then when we look now, we have this lovely view. It's completely healed. And it shows you that, yeah, with persistence and with really approaching the patient differently according to the timing you enter, his general condition, if it's chronic or not, you can achieve very good results. So this is our study that we did on the use of these very large megastents. I think it's a very important study that showed us many things. One of the first things that, yes, we know it gave us, we reached the result of about 82% success rate, but the more important thing is that we showed that in one attempt you reach only 50% success, but if you do persist more, try either by putting further stents, other endoscopic modalities, another 32% will actually reach leak closure. And this was a very important message, not just to us, but to surgeons who very frequently, when you tell them, okay, we put a stent, the patient still has a leak, he says, okay, then endoscopy failed, send me the patient for surgery. But this is a very important message. You have to be patient. As long as the patient is stable and he's doing well, then you continue with the endoscopic procedures. We also clearly demonstrated that these stents are really, really very traumatic. Intolerance is very high, 10%, they just can't stand them, we have to remove them. And they are morbid. We had bleeding, we had perforations with these. Fortunately, no stent-induced mortality, but they are morbid, these very large stents. And yes, they have a lower migration rate than standard stents, and you use less stents per patient. But yeah, the intolerance, the perforation, the strictures really make them a bit problematic. One of the very important findings, I think, that we found in this is that we found that the only factor related to having a major complication was if the patient had an open surgery before, not laparoscopic. And we kept thinking, why is that? Why would a patient with open different from a laparoscopic patient? And we came to this conclusion, which really makes sense for me, that patients with open surgery, they have these massive adhesions. So they're sticking, for example, the jejunal loop just after the anastomosis to the abdominal wall. So this jejunal loop where you have the stent stuck inside is not flexible, it's not pliable. So as you can see this example, this is the stent with its sharp edges coming down here, and this is the jejunal loop. If it's fixed with adhesions, with every push down with the stent, it won't be pliable and go with it. So the stent will really tear through it easily, causing bleeding, causing a perforation. So after this study, we reached the conclusion that if you have a patient with an open surgery, we do not use stents, definitely not the large mega stents. We did work on modifying a stent. This is another stent that we're working with nowadays. It has much less sharp edges and it's much more flexible. We hope that they do give better results. After that, endoscopic internal drainage has become my favorite approach, which is basically like what you do when you have a pancreatic pseudocyst. So you have a leak like this one. Here in a wrong wide gastric bypass, you go usually with a duodenoscope, side viewing endoscope. You pass a wire through the track to reach the leak cavity. You put your double pigtails, and usually in a few weeks' time, when you put it out, things look better. And of course, these have a huge advantage. You don't have the massive pain of the stents. You don't have the major complications. And many of the experts worldwide say, okay, now you shouldn't use stents anymore. You should always use endoscopic internal drainage. But I'm really against this one-for-all approach, because you will see some examples. For example, this is an example of a patient also with a leak post-gastric bypass. Here, this is the view in the lumen. Actually, this is the lumen, which is apparently very stenosed, and this is the leak. Now, we know from the basic surgical principles, if you have a distal obstruction to a fistula, it is one of the major causes that will stop the healing. So no matter how many pigtails you put in this hole, as long as the pressure is high below, then it will never heal. So in this case, you can't just put an endoscopic internal drain. In this case, we put a stent. And we left the stent for several weeks. And eventually, it did heal the stricture, and at the same time, it healed the fistula. So you really have to individualize this approach. This is an example of a patient who actually had an esophagogastrostomy, who had a major leak. And as usual, we're really happy to go through the leak with the endoscope. So yeah, here we're out of the leak. And actually the gastric sleeve, you can see it here on the left side. And this is the abdominal cavity. So yeah, this is the sleeve. So what we do now, previously we had this conception that to do endoscopic internal drainage, you must have a contained leak cavity where you can put the pigtails. But this case demonstrates that this is not a prerequisite, actually. In this case, first we tried to put a stent. Because the lumen was very wide, we put a partially covered stent, but even when it stayed in place, the contrast came out and came through the fistula again, so we knew this is not a proper solution in this case. So we pulled out the stent, we went into the leak cavity, we put the pigtails. You can put as many pigtails as you want in the cavity. So this is the image with the pigtails in place. The patient had a feeding jejunostomy, which is something very important. So after several weeks, it's fine, but there's a very, very little streak of a leak that's remaining here. So we just extend the duration. We exchange the pigtails and put the patient on oral feeding. Now he can feed. After 4 weeks, it's okay. And finally, you reach a situation where the leak has completely healed. I'm sorry, I'm just running quickly due to the time. And you have a healing of the leak with endoscopic internal drainage.